All right, it's 12:31, so I'm going to get started. Hi, everybody. Thanks for hopping on. You're welcome to turn on your cameras if you want to, and no pressure to if it doesn't feel good. My name's Dr. Ari. For those of you who I don't know personally, I am continuing with my theme of expanding upon and hopefully shedding a little bit of light on common reproductive conditions. My last open forum, I talked about endometriosis, and today I'm going to chat about polycystic ovarian syndrome, or PCOS. So, what even is PCOS? And it feels important to note that this is actually my definition of PCOS. As medical professionals and researchers learn more and more about this condition, we're able to find a lot of different definitions online. So, how I tend to define PCOS is as a complex and dynamic metabolic syndrome that results in ovulatory dysfunction. It is actually the most common endocrine disorder in premenopausal women. And it likely results from a combination of blood sugar dysregulation, hormonal imbalance, and environmental factors. So, a lot of buzzwords there. Metabolic syndrome is pertaining to the metabolism, obviously, and then an endocrine disorder, meaning organs that give off hormones and respond to hormones. So similar to like the thyroid and the pancreas and the adrenal glands. And I would be remiss if I didn't just touch on this before going on, which is that the name PCOS is actually a very misleading name. And that's because not all individuals that have PCOS have cysts on their ovaries. So we hear polycystic, we think multiple cysts. We assume that anybody who's been given this diagnosis must have ovaries full of cysts. And I'll touch a little bit more on that. It is often the case, but it's not always the case. And I think we tend to have sort of a negative connotation with the term cyst, where that we think abnormal. And that's really not the case in PCOS, that the cysts are present are actually quite normal from a physiologic perspective. So some names that I think are a little bit better suited to actually describe this condition and what's going on. And none of these are names that I've come up with. They're actually names that have been proposed by people who are more important in the medical community than I am to take the place of PCOS, are metabolic reproductive syndrome, persistent ovulatory dysfunction syndrome, or ovarian dysfunction syndrome. All of these names just more accurately describe the physiology of what's going on with the ovaries, and notice that none of them talk anything about cysts. And so this is just a common question that I get from my patients all the time when we're talking about a diagnosis of PCOS is, okay, well, does this mean my cysts have ovaries on it? And the answer is sometimes yes. And the reality of the situation is it really doesn't matter in how we're going to treat you. And I apologize ahead of time for how crazy the next slide looks. So I am really passionate about giving an anatomy lesson. And if this just makes your brain a little bit crazy, you can tune it out. And I actually want you to tune out a lot of the colors and the noise anyways. But whenever we're talking about a pathology or something that is going sort of quote unquote wrong with the body, I like to talk about, okay, well, what is normal to begin with? So over on the left-hand side of the screen here, I'm going to talk about what generally happens normally in terms of communication between the brain and the ovaries during a normal menstrual cycle, which we'll call just 28 to 30 days, even though it tends to vary a little bit. So over here on the left, we have our super happy brain. Over here next to it is a bunch of colorful neurotransmitters. We're going to completely ignore this, but this is kind of the input into the brain. So we're going to think of communication during a normal menstrual cycle as if the brain is like a coach. He's calling the shots. And the brain is going to send a signal to the ovaries saying, okay, it's time to get started with this cycle. And we're going to think of the ovaries over here, both ovaries, kind of like the team. And once the brain sends a message to the ovaries that it's time to get this party started, the ovaries' job is to kind of pick the best player from the team or the best egg. And once the team says this is the one egg we want to focus on, the brain is going to spend all of its energy that month focusing its energy on growing this one egg. And the ovaries then start sending out a bunch of hormones, particularly estrogen, and that's what primes the uterus and tells the uterus, okay, let's get ready for a potential pregnancy. And then the brain, once the uterus is ready and the egg is nice and juicy, the brain sends out a bunch of hormones, specifically FSH, and the ovary responds to that by releasing the egg for ovulation once that egg is ready. And then if the egg is met by a sperm and fertilization occurs, the body goes on to create a pregnancy. But if that doesn't happen, then we have a menstrual cycle and so on and so forth. In PCOS, what's a little bit different is that the communication between the brain and the ovaries is a little bit more complicated. So in this case, the brain's a little bit more angry and has to shout at the ovaries a little bit more. And the brain is still trying to send out those messages, those hormonal messages to grow an egg. But the brain is maybe a little bit less effective at sending out this message, and the ovary is also a little bit less receptive to hearing the brain's commands or the brain's coaching. And so what happens is the ovary receives these signals coming from the brain to ovulate, but it doesn't respond as expected. And instead of picking one egg to have the body and the brain focus all of its energy on, the whole team of eggs starts growing, and they grow a little bit less effectively. So instead of the ovary growing one juicy egg inside of a follicle that's then ovulated, when the brain senses it's time to do so, there's a bunch of eggs, we'll say anywhere from 5 to 15, that get sort of developed. And so they get bigger, but they don't get big enough that the brain ever receives the message, okay, it's time to ovulate. And so because of that, because of the lack of ovulation, the menstrual cycle changes, and sometimes it changes to the point that there isn't a period at all because an ovulation isn't occurring. And the brain keeps trying and trying and trying to get the ovary to ovulate, and the ovary keeps saying, I'm sorry, I'm sorry, I'm sorry. We do not have an egg that's big enough to do so. So one thing that I'll just mention here before moving on, because I think it's important to note, is that these eggs over here on the right side of the screen, which are, oops, sorry, I'm going to go back here, that are technically within what we call follicles, which are kind of like the house or the cocoon that the egg gets grown in, are actually the sort of cystic structures that we talk about when we're talking about PCOS, which is why I'm saying they're not abnormal. It's not a bad thing. The ovary is doing what the brain is telling it to do. So the ovary becomes filled with these sort of fluid sacs that have a bunch of small underdeveloped eggs inside. So that's what's going on, but what are the common symptoms of PCOS? What are things that patients come to that I sort of suspect this might be going on? Irregular menstrual cycles are obviously a big one because of what we just talked about. If there isn't an ovulation that's occurring, that normal monthly cycle, maybe 26 to 30, 32 days, becomes quite spaced out because it takes so much longer for the ovary to respond, if it ever responds at all, to the brain's communication to ovulate. Polycystic ovaries are an obvious one because of what we just talked about. But again, it's possible to have PCOS without having that. Male pattern hair growth and hair loss is another thing that we look for. The medical term for this is hirsutism. And the reason for this is actually because of elevated levels of testosterone, which are common in an individual with PCOS, but again, not necessary to receive this diagnosis. And so elevated levels of testosterone will both cause hair to grow in places that we typically think of, like a female body individual not wanting hair, maybe on the upper lip or on the chin, sometimes around the chest or the nipples. And then hair loss in the same way that we think of older men losing hair, which is like a receding hairline or sometimes from the top of the head. So we tend to see that more than just a diffuse hair loss where there's like excess shedding. We actually think of certain patterns with PCOS. Um, Insulin resistance is another thing. It's less of a symptom and more of a lab finding where I see elevated levels of fasting insulin and maybe higher blood sugar levels. But there are also some signs that we see physically on patients that make us think of insulin resistance. Sometimes that's some increased abdominal fat, or sometimes that is some excess skin tags around the neck, or there can be some darkening of skin under the armpits or in skin fold creases. So those are all things that I either look for in a physical exam or ask patient a question about. High cholesterol is something, again, that's more of a lab finding and less of a symptom, but that sometimes goes with it just because of the general changes in metabolism in an individual that has PCOS. And then infertility is also sort of a byproduct of PCOS, and it's actually the most common cause of female infertility that we know of. So if a patient is having trouble getting pregnant, I often have to think of PCOS. So what causes PCOS? We've talked a little bit kind of about that hormone cascade and what some of the presentations are. There isn't a precise etiology or known cause of PCOS. I tend to think of it a little bit more as like an umbrella, and you can have a lot of different factors that ultimately lead to ovulatory dysfunction. Um, we do know that there's a genetic component. We know that women with a family history of PCOS are at higher risk of developing the condition. Like if a patient has a mom or a sister or even an aunt, it does increase their likelihood of having this condition. Altered hormone activity is kind of an obvious one. The big hormone that gets talked about the most is testosterone and having elevated levels of testosterone. There are a lot of other sort of hormonal imbalances that we see within PCOS. Sometimes there can be elevated levels of estrogen. Sometimes I even see lower levels of estrogen, though. And then hormones that I think get talked about less that I really care about when it comes to PCOS are the hormones that come from our adrenal glands, like cortisol and DHEA, both of which are the oftentimes impacted by chronic stress and just the lives that we're living. So that's a roundabout way of saying that that stress can be a really big cause of PCOS. Dysfunctional ovaries, which I chatted a little bit about in that colorful slide a few slides back, where the ovaries are just hearing the brain less. And again, I think that mostly can be due to genetics. It can also have to do with environmental factors like diet and lifestyle, exposure to endocrine disrupting chemicals, which are in a lot of like non-organic meats, and the products that we're putting on our body for like skincare or perfumes or sunscreens. And then altered insulin activity, which is, I think, sort of primarily the product of the lifestyle that we all are living, and is also, again, a little bit of a genetic predisposition. So how is PCOS diagnosed? When I'm talking about an umbrella diagnosis, what I kind of want to say is that I look at PCOS and I say, okay, there's some ovulatory dysfunction going on, but I'm not necessarily following any sort of diagnostic criteria. I focus really heavily on patient history. So I'm listening for things like my periods are really irregular. Maybe they happen every 40 to 60 days, or maybe I haven't had a period in over a year. So I'm trying to pull that out of a patient history. During a physical exam, I may see those signs of elevated testosterone or elevated androgens that raise my level of suspicion. Sometimes when I'm doing a pelvic exam, I'll feel for the ovaries to see if they feel at all enlarged or if they're at all tender, because sometimes when there are those cysts present, it can create some unexpected discomfort on a pelvic exam. I definitely do a lot of labs in the patients that I suspect may have PCOS. The labs that we're looking for are testosterone, I'll often run an estrogen and a progesterone as well at different times in the cycle. And then FSH and LH, which were those hormones that I kind of pointed out that are being communicated between the brain and the ovaries near ovulation, are definitely labs that run that kind of help to diagnose PCOS. And I'm not going to get too into the weeds about the patterns that we see, but there are very specific patterns amongst the hormones that I've mentioned that would be pretty indicative that there was this kind of anovulation or lack of concise communication going on between the brain and the ovaries. And then ultrasound is a very easy way to just take a peek at the ovaries without any sort of radiation or risk to the patient, just to see how many follicles do you have? Are they bigger than we would maybe expect? This image over here is an ultrasound of an ovary that appears polycystic. We kind of talk about this appearance of looking like a string of pearls on an ultrasound that would imply that there was something funky going on between the brain and the ovaries in terms of communication. None of these follicles are big enough for the brain to send a signal for them to be ovulated, but we can see them, which tells us that they're growing and they're just fluid. You can't see the eggs. These are just follicles with fluid in them, and the eggs are microscopic. But this is an ovary that would be pretty classically diagnostic of PCOS. And so those are the tools that we use to diagnose PCOS. And then I very intentionally have criteria in quotation marks, just because I take the criteria lightly because of this umbrella diagnosis, where maybe somebody has aspects of PCOS, like they may have irregular menstrual cycles, but they don't have signs of elevated testosterone in their body, and their ultrasound doesn't look like this. Maybe they have a few follicles. I would still treat that person the same, which is why I have criteria in quotation marks. But technically for the criteria, there's a list of 3 different things, and you have to have 2 of the 3 things to meet the criteria. So what is the conventional treatment for PCOS, and why does it sort of quote unquote work, and why does it really not work? So birth control is the common conventional treatment for PCOS. Most of the time, if you're going to go to just a conventional Western medical doctor or an OBGYN, they will recommend that you start birth control if they suspect or confirm that you have PCOS. And so why does taking the pill sort of work? Well, birth control pills contain hormones that help to regulate the menstrual cycle, and they typically have a combination of estrogen and progestin, which is a synthetic form of progesterone. And by providing these hormones to the body when you're taking them orally, birth control helps to regulate and kind of stabilize the menstrual cycle, which tends to be irregular in PCOS. So this tends to help manage those symptoms like irregular periods or super heavy periods, because your lining builds up when you're not having a period for a long time, and then you shed it, and so it feels extra heavy. And so birth control sort of, I would say, falsely gives you a menstrual cycle, because most birth control pills, it's recommended that you take a sugar pill for a week at the end of 3 weeks of hormonal pills. And it's that withdrawal of the hormones that causes you to have a bleed. So it's not technically your body having a real period, it's just that withdrawal from the hormones. Birth control can also lower the levels of testosterone, just because you're getting an increased level of estrogen. And so that in and of itself kind of balances out the symptoms that come with elevated levels of testosterone, like the unwanted hair growth or hair loss. And since PCOS often involves like multiple small undeveloped follicles that don't release an egg, birth control, when it suppresses those follicles or suppresses ovulation, it can tend to make those follicles shrink up, so you don't see them as much on an ultrasound like the one I showed you on the last slide. So, at face value, sure, it seems like this works, but the big issue is that once birth control is stopped, all of those other symptoms just come back because the underlying cause hasn't been addressed, whether that's stress or insulin resistance. And it has no effect, birth control, on the miscommunication between the brain and the ovaries. And I actually often use the analogy of sort of like an unhealthy relationship when I'm talking to my patients who have maybe been on birth control for a really long time, who have PCOS and they're interested in coming off. I say, taking birth control for PCOS is kind of the equivalent of being in an unhealthy relationship with a partner and knowing that you don't have effective communication skills. And every time you talk, you get into this big fight. So you decide, okay, instead of talking, we're sick of fighting. So instead of talking, we're just not going to talk. And that works, right? Because you stop fighting, you're not having any communication. But the second that the silence gets broken, or you decide, well, we actually have to talk here, or somebody wants to get pregnant, you just start fighting again. So it's not actually working at those communication pathways or underlying cause. So it's really just a band-aid effect. And it's a fine band-aid effect if the symptoms of PCOS are making your life miserable. But it is just that, it's a band-aid. So I have no problem with, short-term use of birth control just to kind of get control of your life again. But it's really important if you really want to truly reverse what's going on and kind of help to regulate your menstrual cycles, that you just view it as that, which is a short-term solution. So what are my treatment goals with PCOS? And this says 1, 2, 3 here, but it's really not, this is not in a specific order of importance. My biggest goal, though, so I think 1 is appropriately said, is to prevent the endometrial thickening, which can lead to a risk of uterine cancer. So the endometrial lining is that inside lining of your uterus, and it's what builds up in a normal menstrual cycle to prepare for a potential pregnancy before shedding and releasing at a period, during a period when a pregnancy doesn't occur. So in PCOS, because the periods are often irregular or absent from the infrequent or complete lack of ovulation, the lining of the uterus just keeps getting bigger and bigger and bigger because there's so much estrogen being inputted, and there's not a lot, if really any at all, progesterone, which is what causes the lining to ultimately shed once it drops, because progesterone is the product of ovulation. And so over time, if there's not a period, that lining can get thick and thick and thick. And over time, that can increase the risk of uterine cancer. And so I'm always talking to my patients about my threshold of comfortability with them not having a period. And I think everybody is a little bit different. Everybody, being physicians, everybody has kind of a different threshold. But for me, that's about 6 months. If the tools that I'm employing, are not getting you to have a period, or if you come to me and you already haven't had a period for greater than 6 months, I will sort of up the ante in terms of what I'm willing to do to get you to have a period, just to protect your uterus, to get you to have a nice heavy shed. So that's a risk that's associated with PCOS that I'm continually surprised by the lack of education about when a patient comes to me. I also really want to improve the metabolic outcomes. So things of like risk of heart disease, risk of diabetes that come from that underlying insulin resistance, which I'm sure on the Coeur d'Alene website, one of the other docs has at some point talked about insulin resistance. So I'm not going to get too heavy into it. It's a really, really big problem, and it's a growing problem just given our modern relationship and connection to the foods that we eat and how we're eating. But essentially, when our blood sugars are chronically elevated, our pancreas is forced to compensate by pumping out a bunch of extra insulin, and insulin can, over time we become sensitized to it, and the high levels of insulin in our blood and the high levels of blood sugar in our blood can really damage vessels in our heart, and they can lead to a complete shutdown of the pancreas, which is what happens in diabetes. And so I really like to try to reverse those metabolic outcomes in my PCOS patients. And then I obviously really want to support reproductive goals, whether that's a patient desiring pregnancy now or in the future, or a patient not desiring pregnancy and wanting to have more control over their cycle so that they can know when a potential pregnancy in their cycle would occur, which is really hard to know if you're not ovulating regularly. And notice here how none of my goals are to sort of regulate the menstrual cycle, which is the obvious thing that we think about when treating PCOS. And for me, that's because I regulate the menstrual cycle by focusing on these other things. And I really view the period as a vital sign. And so as I see a period start to creep back in, whether it's farther apart at first and then it starts to get closer and closer and more regular, I view that as knowing that we're on the right track by treating these underlying things. But none of the treatments I recommend are actually to get you to have a period, they're to address these other things. So, what is my approach then? I focus a lot on nutrition. Um, as with all things, there isn't really a one size fits all approach to nutrition. And often the dietary recommendations I make have a lot to do with other facets of a patient's health, like what else they have going on. But generally, I'm trying to optimize blood sugar and regulate hormones, addressing gut health because the hormone and gut microbiome connection is a really big thing and something I could do a whole nother one of these talks on. But I tend to do this not only with key nutrients, and recommending like a whole foods diet with, lean proteins and lots of diversity in terms of color and um, healthy fats and limiting sugar. But I also do this by helping patients to understand the relationship between the um the hormonal cascade in their cycle and how that cascade is impacted by either how we eat or how we don't eat, like with a fast. And so that's actually, I think, what I'm going to present on for my next open forum is that complex relationship between hormones and blood sugar and how we can kind of harness the power of fasting and nutrition to enhance all of the parts of our cycle. So from a nutrition perspective, that's what I'll focus on with patients. Movement is an obvious one, just because in addition to being really good for sort of mental health and stress reduction, which is my next bullet point, it's also really helpful from an insulin resistant sort of blood sugar perspective to use the fuel, to use the blood sugar that's circulating through our bloodstream so that we don't develop insulin resistance. So I'm often talking to my patients about what kind of exercise they're doing. And I'm sure there's some research on like that best kind of exercise for PCOS. And I'm not totally sure what the data is saying these days, but I love things like strength training, gentle weightlifting, walking, gentle approaches that aren't going to stress the body, but that build muscle strength. Um, Mental health and stress reduction is a big one. Sometimes I'm just recommending things like meditation or yoga or focusing and prioritizing sleep or seeing a therapist. And sometimes we're having the big hard conversations around quitting a job or leaving a bad relationship, because these are the things that really do impact our stress response and the cortisol and our general adrenal health, which, as we touched a little bit on, is totally tied into that hormonal pathway in PCOS. Nutraceutical therapy is another thing that I employ sometimes. The big one that I'll mention here, just because I can't think of a single PCOS patient that I don't have taking this, is myo-inositol, which is a modified sugar that really helps to clean up the communication between the brain and the ovaries and can kind of help to get the ovaries back online and kind of listening and hearing the messages that the brain is sending out a little bit better. Sometimes I use some things like CoQ10 that again help with energy both in the brain and in the ovaries. There's a lot more there, but these things tend to be pretty nuanced, and so I'm not going to get too heavy into them. Botanical medicine is a really big one. Vitex berry or chaste tree berry is one that you'll see all over Google that's really beneficial in PCOS because of the way that it acts in supporting healthy progesterone levels in the body, which is really beneficial in PCOS. I do occasionally use bioidentical hormones in PCOS, specifically progesterone. Again, in that case, when I'm saying my threshold for somebody not having a period is 6 months before I start to get worried about their uterine lining getting too thick, I kind of combat that with a short duration use of progesterone that I'll then withdraw really quickly to try and stimulate a bleed in the body to kind of thin out that lining. And so that tends to be why I use progesterone. Occasionally I'll cycle it where I'll have patients use it for a couple weeks every month. And then rarely I use pharmaceuticals, specifically in my PCOS patients who are desiring immediate fertility, trying to get pregnant and really struggling with that because of the infrequency of their ovulation or sort of the quality of their ovulation. And so there are a couple medications on the market. Some of them intended for, and some of them used sort of off-label as an additional kind of side effect of the medication that enhance the quality of our ovulation, and they kind of help with egg or follicle recruitment. And so it can help you grow a really nice, juicy follicle when maybe you're struggling not to. Again, more of a band-aid approach, doesn't actually fix any of the sort of underlying pathways that are going awry in PCOS, but fertility is a really hard and can be kind of a lonely and isolating journey. And so I don't hesitate to use those medications when I need to, and a patient's really struggling and we're not having much luck with any of the other things that I've mentioned. But yeah, as with all conditions, very, very individualized. And in addition to talking about PCOS, I try not to hyperfixate on that and really get more of a holistic view of what else the patient has going on in terms of gut health and potentially any other autoimmune conditions that can also contribute and kind of make that brain ovary connection a little bit funky. So we just do a really thorough history. But I think that's all the info that I have to spit out at you. I'm happy to take any questions if anybody has any specific questions, or we can just kind of wrap up there, but I'll give folks a couple minutes just to chime in. And you can oh, it looks like there's something in the chat. You could also just, you don't have to wait for me to call on you. You can just jump in and ask if you have anything that's coming up for you. Ricky said in the chat, weight gain or inability to lose weight should be listed here too. I'm assuming that you are talking about under the common side effects. And yes, absolutely. And I think that that's often that's kind of a product of the hormonal imbalance, as well as some like of the adrenal stress and the insulin resistance, which tends to cause that weight gain. But absolutely, that's a common side or a common sign that I hear patients being concerned about.
I don't have any questions, but thank you. This was very helpful.
Yeah, you're welcome. Thanks for joining in. All right. Anybody else have anything that's come up for them? And if not, I'll go ahead and end the meeting here, and then we'll get this uploaded to our website. So if there's anything you ever wanted to reference back to, feel free to use that resource. But thanks, I appreciate everybody tuning in today. I'm going to go ahead and stop the recording, and then I'll just hang on for a minute or two in case anything comes up.
Thank you.
All right, thanks everybody. Have a good rest of your day.